So as Kelly mentioned earlier, my name is Terry Stillwell. I am actually the pediatric infectious disease part of the comprehensive program. And it has been a pleasure to work with my other colleagues to help advance the care of our patients. And so I get the honor of introducing our medical student extraordinaire, Ashley Shaver. And also she will be joined by Allison Hopper, who is the mother of one of our patients, Miss Layla. And they are going to start off our primary immune deficiency talk by discussing the newborn screen. After she talks about screen.
Also, if you haven't been aware of this yet, there is CME credit allowed for the whole day. And so it is 5.25 credits, and this is our activity ID. Otherwise, you can also find it under Immuno-Hematology Symposium is the name. And so you can actually find it that way. But make sure you get your credits. All right. You can let her walk around. All right, so I have the pleasure of being here to not only kick off our primary immune deficiency segment of the day, but also introduce a very unique case that we'll talk about in a little bit. So I'm going to be with you for the first 5 minutes, and then hopefully Layla and her mother will join us for the next. But Layla wants to join us now, so enjoy. All right, so the outline for the next 15 minutes. So first I'll go over an overview of what SCID is, so severe combined immunodeficiency. Next we'll talk about the TREC assay on the newborn screen. And then finally we'll hear from Allison and Layla. So to start this off, T-cell deficiencies were first made famous in 1971 with the birth of David Vetter, also known as the Bubble Boy. Layla wants to say hi. So when he was born, he was immediately put into something like a bubble, and he remained there for over a decade of his life. Everything that went into that bubble needed to be sterilized for risk of infection, including toys, plates, everything like that he needed. At age 12, still living in a bubble and not having a matched donor, they decided to go through with a transplant with his unmatched sister. Fortunately, the transplant went pretty well. However, a few months later, he developed what appeared to be DIC and unfortunately passed away. On pathology afterwards, it showed that he probably passed away from Burkitt's lymphoma. And David had what we know of as SCID. So quick overview of SCID. So SCID is a group of inherited disorders characterized by absent T and B cells. And then there's the subtypes of SCID that are characterized by lack of B cells or low B cells, even though they don't work, and or NK cells. And these are the two types. So we have the classic SCID, which is what we think of with the babies that become very ill at a very young age, have virtually no T cells. And then we have the variant and leaky type SCID, which is very variable disease, encompasses a lot of different types of disorders. T cells are variable, phenotype also very variable. In classic SCID, the classic presentation, at birth children are usually pretty much okay, and this is why we don't catch them for a couple months. But after a few months with the waning immune system or no immune system, they do develop recurrent and very severe infections with atypical pathogens, chronic diarrhea, failure to thrive, and rash. And here's a picture of a child with a SCID rash. And unfortunately, by 2 years, there's universal mortality without definitive therapy. So what we decided to do about it, a couple of years ago, the Secretary of Health and Human Services announced that they wanted to add SCID screening on the newborn screen via the TREC assay, which I'll talk about in a second. And so that was started in 2010. Michigan joined in 2011 on October 1st. And since 2010, 18 states now have it on their newborn screen, and in the next year we should see another 14 states joining. So what is the TREC assay? So TREC stands for T-cell receptor excision circles. These circular DNA are made during T-cell VDI arrangement, and they're made in the thymus when the T cells are going through maturation. And so these signify T cells that are fully functional and ready to fight infections are now out of the thymus and in your circulation. And so if you have very low TRECs, that signifies you have low T cells, and we should work you up further. Anything less than 25 will garner a red flag on the newborn screen. So that brings us to Miss Layla. So Layla was actually the first patient with a severe immune deficiency identified in Michigan with a newborn screen. She was identified in October of 2012. She had a newborn screen TREC assay of 2. At that point, she was referred to the University of Michigan, where we tested her again, and she had a TREC of 1. After a big immunologic workup, it revealed that she had a very interesting type of immune deficiency, which we consider T low, B low, NK combined immune deficiency. So we looked up further and had some help from some friends across the country, did a genetic workup and found that she had this very rare mutation called a hypomorphic Artemis mutation. This adds additional challenges to her course. Not only is she immune deficient, but also she's intolerable to normal chemotherapy used for regimens for transplants, and also she has a higher risk of B-cell lymphoma. So because of this higher risk, we decided to start transplanting her at a very young age. So far, she's received 3 matched, unrelated bone marrow transplants from the same donor, which is pretty cool. The first 2, we tried to use a non-toxic regimen just because of the fragility with her radiation and sensitivity. And so those didn't work. And then we most recently in the fall did her 3rd one with a very traditional chemotherapy regimen, and it stuck. So she is well past her 3rd transplant now, a few months in, and her recent chimeric studies showed that she's 100% engrafted. So perfect transition. Here is Layla and her mother. Hi, Layla.
I'm Allison, and this is my daughter, Layla. As you can see, she has a lot of energy. Layla was 1 week old when I got a phone call saying that some of her levels on the newborn screening test came back abnormal. When you first hear something like that, your heart just immediately stops. Thank you. And it's like all of a sudden, you forget how to speak. The nurse said a lot of these levels come back as false positives, and little did I know I was in for a new life. The same week, we made our first of many appearances at Matt Children's. It definitely isn't easy to see your 1 week old innocent baby having to get stuck with a needle. Even after the first couple times, it's still hard to watch. Our next appointment, they confirmed that the newborn screening test results were correct, and they needed to do additional testing to find out the exact diagnosis. At about 4 months old, we learned that Layla had one of the rarest types of immunodeficiencies, and that only 6 to 8 cases have been reported in the country. When Layla was 7 months old, we had our first admission to the 7th floor for her first transplant. Staying there for 3 weeks seemed like a lifetime, but it was really just the beginning. At about 20 or so days post-transplant, Layla started having fevers, so we made our first trip to the emergency department. I thought it was just from teething, but it turned out she had gotten the Epstein-Barr virus from the recent donor cells. At that time, I learned that the first transplant had failed. On July 27th, she had her 2nd transplant. Because Layla was so young and could only receive the minimum amount of chemotherapy, we knew this could happen, but I never expected it to be a reality. In mid-August, I was told that the 2nd transplant had also failed. I was mad, sad, and disappointed, among many other emotions, but I knew we'd have to try again, and as many times as it took so my daughter didn't lose her life because of this rare disease. In October, we asked the same volunteer donor if he would donate to us once again. I don't know him, but I have to say he has one of the biggest hearts, and he is truly a hero to me and my family. Every hospital stay got harder and easier at the same time. Harder because I had to watch Layla go through this process again, and easier because I kind of knew what to expect. The 3rd transplant had a very special regimen made just for her, which included going through 15 days of chemo. On November 6th, Layla got her 3rd bone marrow transplant. Our motto was, 3rd time's a charm, and by the grace of God, it was. Finally, all of the heartache and disappointment became worth it. The support of my family and friends and doctors, nurses really helped me survive through all of this. Layla, being the smart, funny, and outgoing girl she is, helped me stay positive. I knew I had to be strong for her like she was for me. Layla is now 114 days post-transplant, and she's doing great. I can't begin to thank everyone who made this possible. I hope one day that Layla will want to help kids and their families, just like the whole BMT team did for her and the donor. I'm proud, honored, and blessed to be able to call her my daughter. Thank you.